Good afternoon. It's my pleasure to introduce the next session, which is Pharmacotherapy for Transgender Youth. So my name is Michael Rieder. I'm a professor at the University of Western Ontario in London, Ontario, Canada, pediatric clinical pharmacologist. I'm also one of the senior editors of the British Journal of Clinical Pharmacology. It's my pleasure to introduce the session. Just a couple of housekeeping items. First of all, we're going to run through the slides as one unit. It's a unitary presentation, so there's no breaks between 2 or 3 speakers. There will be plenty of time for Q&A and comments at the end. On that topic, there's 2 ways to answer questions or give comments. The first is if you go into the app, go into the session, there's a live chat option. If you put question or comment in the live chat, Lucy will make sure that they appear on the screen for us to answer. Second, you can talk at one of the 4 labeled mics about the session. So without further ado, so our first speaker, we have 3 speakers today. So Professor Tseng is a pharmacist and associate professor at the University of Toronto, who's going to be our first speaker. She's talking, going to bring the introduction on her perspective, followed by Lauren Sestedi, who's a associate professor at the University of Washington, and she's going to be talking to us, providing pharmacological insights. And I'm going to finish off with plotting the path forward. So without further ado, I'd like to introduce our first speaker, Alice, who's going to talk to us about setting the stage for issues in pharmacotherapy in transgender youth, opportunities and obstacles. Alice.
Thank you very much for the kind introduction and the opportunity to be here. These are the disclosures for the 3 of us. And as Michael mentioned, this will be a 3-part presentation. So I'm going to start off with a bit of background on the current landscape of gender-affirming care in youth. Dr. Cirrincione will then talk about clinical pharmacological considerations in transgender youth, and Dr. Rieder will finish up with a summary on gaps in knowledge and a call to action. Now, to start off, I wanted to go over some basic terminology, and many of you are probably familiar with this, but just to make sure we're all on the same page. Some basic terms. Sex is generally referred to as the biological sex or sex assigned at birth, based upon appearance of an infant's genitalia and or sex chromosomes. If you look at the cartoon on the left, the gingerbread person or the genderbread person, sex, can be thought of as what appears between the legs. Gender refers to characteristics and roles of women and men based on social norms, such as feminine or masculine. Transgender is any person whose gender identity, so what's in their head, does not align with their sex assigned at birth. Gender dysphoria refers to distress experienced because one's gender identity does not align with their sex assigned at birth. And I just want to note that not all transgender and gender diverse people experience gender dysphoria. Now, globally, it's estimated that 2% of the population is comprised of transgender individuals. So that works out to be about 25 million people. Which is not an insignificant number. Next, moving on to gender-affirming care, this slide really is to illustrate the holistic approach to care. Let's see if this pointer works. Gender-affirming medical care, this top balloon in the top right-hand corner is what we'll be talking about today, but I just want to point out that it is merely one component of various aspects of care, which can include social gender affirmation, mental health care, family support, economic, legal considerations, addressing social determinants of health, as well as intersectionality. With gender-affirming medications, the goal is to achieve changes that are consistent with a person's gender identity. So that can involve either lowering endogenous hormone production and or increasing the affirmed hormone to develop secondary sex characteristics. There are a couple different categories of gender-affirming medications that we'll talk about. First are the puberty suppression or puberty blockers, commonly known as GnRH agonists. There's feminizing hormone therapy, most commonly consisting of 17-beta estradiol, with or without spironolactone, and masculizing hormone therapy with testosterone. Use of gender-affirming medications has been shown to improve psychological functioning and body image. It can be considered a medical necessity, and in some cases can be life-saving. With puberty blockers, the goal of puberty suppression can encompass a number of points. First is by delaying the onset of puberty. This allows time for an individual to explore their gender identity. Secondly, by delaying onset of secondary sex characteristics. This can be helpful because sometimes these secondary sex characteristics can worsen gender dysphoria. Also, by preventing or delaying this onset, this can improve someone's ability to pass in their identified gender later on in life. Initiation of puberty blockers at Tanner stage 2 or later generally leads to regression of one Tanner stage. These medications are usually well tolerated, and effects are reversible upon discontinuation. Now, with respect to use and practice, this is a quick timeline. The Dutch were the first to publish a case report on the use of puberty blockers started in a person at age 13. That was back in 1998 to manage gender dysphoria. In 2006, the Dutch published their protocol involving 54 participants, and I've got the criteria of the Dutch protocol just outlined in this blue box. So people have to be a minimum of age 12 with lifelong gender dysphoria, which is increased around puberty, psychologically stable, without any other comorbid psychiatric disorders, and have the presence of family support. In 2011, the Dutch launched a prospective study, and the United Kingdom also launched an early intervention study. By 2014, puberty blockers became available through routine clinical practice in the UK. And you can see in 2016, NHS England, their policy stated that hormone blockers will be considered as appropriate treatment alongside psychological intervention, and with guidance to continue to follow the 2011 research protocol as quotes unquote established practice. Now, in 2020, NHS England established a policy working group to review the published evidence on use of puberty blockers and gender-affirming hormones in children and young people. And this group is chaired by Dr. Hilary Cass. The National Institute for Health and Care Excellence, or NICE, was commissioned to review the published evidence. One of the components of this process involved an audit of what was actually happening traditionally in the UK. This audit found that 27% of all young people referred to the Gender Identity Development Service were then referred to a medical pathway. So you can see this medical pathway on the left. There's assessment, then moving on to puberty blocker use, and then followed by estrogen or testosterone therapy, and then later surgery, all as indicated. And so the audit found that 27% of young people were referred to the medical pathway, so about a quarter. 81% of those then received puberty blockers, and 64% of those people eventually received hormone therapy. With respect to the evidence review, what was found was that for gender-affirming hormones, benefits were likely to improve symptoms of gender dysphoria. The review found that this was also likely to improve depression, anxiety, quality of life, suicidality, and psychosocial functioning. The impact on body image itself was unclear. With respect to safety, there can be some bone density changes. One study only also looked at other adverse events, including changes on blood pressure, body mass index, and lipids. So again, you can see pretty small numbers of studies and low level of evidence. As such, the CAS review made the recommendation regarding puberty blockers. Their conclusions were that there were no changes in gender dysphoria or body satisfaction demonstrated with use of puberty blockers. They concluded that there was insufficient or inconsistent evidence on psychological, psychosocial well-being, cognitive development, cardiometabolic risk, or fertility. They also had a statement that there was no evidence that puberty blockers do buy time to think, as the majority of people did proceed to receive gender-affirming therapy. I just want to comment that in their UK audit, although the majority of people did eventually go on to gender-affirming therapy, they didn't actually describe the time frame for moving between these steps. Regardless, the review's letter to the NHS England recommended that puberty blockers should only be offered under a research protocol. Therefore, the NHS England made a policy update in March 2024, so no longer allowing puberty suppressing hormones as routine treatment option to children and young people with gender dysphoria. Furthermore, the government then released an emergency ban effective from June 3rd of 2024. This ban has been extended twice, most recently to be active till the end of December of this year. And with this ban, it makes it a criminal offense for a pharmacist, doctor, or any individual in Great Britain to sell or supply puberty blocking hormones to anyone under the age of 18, or for an individual to possess these medications for management of gender dysphoria. Similarly, you can see similar patterns occurring in other countries across the EU. In this trans health map, you can see that 2/3 of the 27 EU member states do ban access to puberty blockers for people under the age of 18. And in fact, these actions actually are in, they contradict guidance from many international medical associations, as you can see here. All of these associations do endorse use of puberty suppressing agents as a routine treatment option for children and young people with gender incongruence or gender dysphoria. I would also like to point out that guidelines from all these various organizations were reviewed, but ultimately did not inform recommendations in the CAS review. So in their report, they acknowledged the existence of these guidelines, but did not feel they had enough evidence to substantiate use in their recommendations. So I think you can see there's been a lot of tension. There's a lot of back and forth about the quality of evidence versus trying to find the best way forward. With that, I'm going to then pass it on to Dr. Cirrincione to talk about considerations in transgender youth.
Good afternoon. I'm Lauren Cirrincione, and I would like to thank the conference organizers for the invitation to talk. And I'm going to build on Dr. Tseng's excellent introduction to the state of the field of transgender medicine. One of the key outcomes from the CAS report was the call for increased high-quality research around gender-affirming medications for transgender youth. So over the next 10 minutes or so, I'm going to try to make the case for why pharmacology and pharmacologists need to be part of advancing research in this field. This group is well aware, if we take a step back from gender-affirming medications for a moment, if we think about drug therapies more broadly, multiple factors contribute to the safety and effectiveness of medication therapies across the life course. For transgender youth, there are really three factors that emerge to the forefront. These are things like gender, age, and as well as drug-hormone interactions that you can see listed here. Now, as part of the CAS report, there were 8 systematic reviews that were conducted by the University of York. And unfortunately, they did not review pharmacology considerations for transgender youth. However, 2 of these systematic reviews did report on physiologic and hormonal changes that occurred following pubertal suppression, as well as hormone therapy treatments for transgender youth. So over the next few slides, we're going to leverage some of those data and think about how these changes may influence certain pharmacokinetic processes for transgender youth. If we think about drug distribution, there's an emerging body of literature around changes in body composition among transgender youth. These data come from the Netherlands. There is a cohort there of transgender youth who underwent pubertal suppression. It was about 300 transgender youth, and as part of their standard of practice in the Netherlands, they actually used DEXA to measure body composition over the treatment time course. So these investigators in the Netherlands examined longitudinal changes in body composition among transgender youth who had started pubertal suppression. So over 3 years, you can see on the panel to your left, there's data for transgender boys. These are people assigned female at birth who have a male gender identity. And in the panel on the right, these are transgender girls. And those are youth who are assigned male at birth and have a female gender identity. In the windows across the top, those are data for lean mass, and the windows across the bottom illustrate data around fat mass. And the takeaway here was that if the investigators compared changes in body composition over the course of pubertal suppression, and also examined how this related to a referent group of non-transgender or cisgender youth, there was actually a marked decrease in the Z-score for lean mass and a marked increase for the Z-score in fat mass. And this was true for both groups. 3/4 of this clinical cohort moved forward with taking gender-affirming hormones, either testosterone therapy for transgender boys or estrogen therapy for transgender girls. And I'll just guide your attention to the first panel on the left, the data for transgender boys. And again, the investigators noted a marked increase in the Z-score for lean mass during the course of testosterone therapy, as well as a decrease in fat mass during testosterone therapy. And for transgender girls, you can see that there's a marked change in the Z-scores overall. Again, we don't have data around how this actually influences drug therapies for this population, but it's something to think about as we consider how pubertal suppression may influence disposition of medications. Continuing on with drug distribution, knowledge around plasma binding proteins is limited. And at this point, the only data we really have is from a cohort also in the Netherlands, and they actually assessed sex hormone binding globulin during testosterone treatment among transgender boys. And as one might expect, during pubertal suppression, SHBG concentrations did not change. But when testosterone treatment was started, there was a marked decrease in SHBG. This is very consistent with what we know about how responsive this binding globulin is to androgens in the body across different populations. And if you look at the figure on your right, in the middle panel, those are SHBG concentrations during non-transgender adolescents. And you can see how the SHBG concentrations change across Tanner stages, and of course that's influenced by androgenicity as well. So again, we have yet to determine how this may influence drug disposition, but it is certainly an area that we need to think about as we consider medication therapies for this population. Moving along to metabolism, data around drug metabolizing enzyme activity and expression is limited. We understand that there is maturation of major drug metabolizing enzymes during adolescence, and this includes some of the cytochrome P450 enzymes as well. Now, based on available literature, no investigators have established how these drug metabolizing enzymes may be influenced by either pubertal suppression or subsequent therapy with sex hormones. However, available data suggest that there are very few indirect effects on adrenal as well as sex hormones that may contribute to changes in the expression of certain drug metabolizing enzymes. And again, we're thinking about things like DHEA as well as growth factor here. And I misspoke a moment ago. I said there was no change in sex hormones. Of course, if you're giving GnRH agonists, that reliably suppresses gonadotropins, which in turn suppress sex steroids. So based on these data, we really don't know at this stage how pubertal suppression followed by testosterone or estrogen treatment may influence drug metabolizing enzyme activity. And this is certainly an area that requires further investigation to fully understand it. Wrapping up, if we're thinking about drug excretion, again, with kidney function, drug transporter activities, these are all areas that lack knowledge for transgender youth. Extrapolating information from other patient populations, we understand that there could be an influence on modulating sex steroids and the potential implications on activities of major transporter enzymes and proteins. At this stage, we don't know how these changes may manifest and in turn how it may influence drug therapies for transgender youth. There are investigations ongoing around the effects of hormone therapies for transgender people, particularly in adulthood, to really understand how these may influence kidney function as well as ways that we estimate kidney function. So these are areas of emerging evidence and places to keep an eye on. So where does that leave us? As pharmacologists, you play a key role in better understanding how these medication therapies may influence the safety and effectiveness of other medicines that transgender youth may take across the life course. And there are many areas that need to be further explored. But on that note, I'll pass things along to Dr. Rieder to wrap things up.
Thanks very much. So, moving along. So, I think we've heard a nice introduction as to background and some of the issues. So the challenges are transgender youth are complex patients with complex issues, and we have incomplete knowledge as to what's best care, what's the evidence to get this, and how do we get this evidence, and what are long-term effects. So consideration, how do we then move forward? So we talked about the agents that are gender-affirming drug therapy, puberty blockers, and hormonal therapy, so I'm not going to go over what they are. But why is that an issue? Part of the reason as an issue is, for those of you who know me, you know I'm a bit of a historian, and I'm actually a conflict historian, not a medical historian. And because I find medical history to be blunt, a bit depressing, because it's largely a account of poor patients suffering suffering at the effects of well-intentioned but turning out bad interventions. So if we look at the history of medicine, there's lots of cases of well-intentioned physicians with host efficacy treating people things that don't work. So beta blockers are contraindicated in heart failure. Well, no, they work. Colloid's better than crystalloid for fluid replacement. It's not. If you fix a fractured scaphoid, it's better than immobilizing it. It doesn't. Flecainide reduces mortality if you have supraventricular tachycardia. It actually increases it. Triglyceride is a great drug for diabetes. It causes liver failure. So good intentions are no substitute for good evidence. So the optimal management of patients with complex cases is increasingly seen to be dependent on multidisciplinary care, which includes physicians from many disciplines, but also psychologists, social workers, pharmacists, and other partner health disciplines. And there is robust evidence in the field, things like cystic fibrosis and diabetes, that this improves care, reduces morbidity, and appears to reduce mortality. So what's the best area for complex cases? As a pharmacologist and someone whose career has mostly been centered around drug safety, an observation would be sometimes the best drug is no drug. And there's some key questions about when you plan a drug is what's the drug, what's the dose, what's the duration, and how do you monitor for success or failure? So Claude Bernard, for our morning talk, David Nutt gave a great perspective on psychedelics, and I think Claude Bernard nicely encapsulated this, the father of modern physiology. Tout est poison, rien n'est poison, c'est une question de dose. Everything's poisonous, nothing's poisonous, it's just a question of dose. And also a perspective that the risk-free drug does not exist. Inside every course of drugs is a adverse drug reaction struggling to get out. So how important is it to pick the right drug therapy? Well, I'm going to pick a relevant example from my area. I'm a pediatrician in terms of childhood cancer. So the care of children with cancer is probably one of the best examples in pediatrics anyway of how multidisciplinary care coupled with robust research can impact outcomes. So if you look back here, so when I trained in Detroit back in the began my medical career in the 1970s, trained in Detroit in the 80s, cancer mortality, we're doing a decent job, not a great job. But if you look here, this is status from the UK. Here we have a graph from Germany. This is Canadian trends. American trends are much the same as our European trends. We can see a steady increase in survival for all forms of cancer, such that actually now, if you look at some of the lymphomas and ALLs, our cancer survival rates approach 90% for 5-year survival. And this was achieved with multidisciplinary care and extremely robust research. So how does that apply to gender-affirming drug therapy? So what are the pros of gender-affirming drug therapy? Well, enhanced quality of life and psychological well-being and alignment of one's body appearance with one's gender identity. Those are our good pros. What are the cons? We've heard about the cardiac and metabolic risks. We don't know about the effects on fertility and reproductive health, weight gain, or mood smoothing. So there's some risk we believe to be the case. So gender-affirming drug therapy, puberty blockers, were designed to delay puberty in patients with a fixed gender. They were designed to meet the needs of a fairly small number of patients with a in which gender and sex were aligned. Sex hormone therapy has been used for many decades, also in patients in whom gender and sex are aligned. However, this is not the case for our transgender patients. Also, is primarily done in the context of an adult, especially for hormonal therapy. So while short-term therapy appears quite safe, there's a real knowledge gap in the application of this, especially for longer-term efficacy and longer-term safety. So questions that I would wonder about is, what's the right dose? How do you individualize the dose? Because from the 11 o'clock session, we heard about pharmacogenomics. Well, are there issues? And we've heard about the other factors that apply to individual patients. Do you change dose as you change age? How does it impact other risk factors? And how do you monitor for efficacy and safety? So there's some logistical and ethical issues as well. So examples are, do we have equal access? So hormonal therapy is not typically very expensive. In the US, it costs about $150 USD per year. Puberty blockers are a little more expensive, about between $2,500 and $3,000 a year US. Many of which, by the way, are not covered for that indication by drug plans, at least in the US and in places in Canada. The issue of informed consent is problematic, and we're going to talk about that in just a sec. And there's some key ethical issues as well. So when you ethically have to consider benefits, non-maleficence, autonomy, and justice. So how do we consider those issues? And how do we think about informed consent? So ethical medical care and ethical drug therapy requires informed consent. So in the case of gender-affirming drug therapy, what is the age of consent? In some countries, it's defined. The age of consent is 16, 18, 21, whatever the legislature says it is. In some, it is not. I come from a country in the legislation, the jurisdiction I practice in, there is no age of consent. It's determined by capacity. So theoretically, if an 8-year-old had the capacity to make consent, you could actually perform cardiac surgery on them. I don't think anybody would, but it's defined by consent. So in the UK, the age of consent is 16 years. Under 16 years, capacity is determined by having what's called the Gillick competence, which is sufficient maturity and understanding to make the relevant decision. So that introduces an interesting set of ethical and problematic issues around consent. So what is our path forward? Because this has become with the publication of the Cash report, it's become a somewhat contentious issue. So there are some factors that are clear. These are facts. A number of people are gender dysphoric, and there are therapeutic options that can be used for these people. Those are facts, and those facts are not in dispute. There are certain facts that are in dispute. So what's the best model for treatment? Who should be treated? What should they be treated with? How are they supported? So what does the multimodal care look like? And what are the barriers to achieving appropriate multimodal care? What's the evidence for efficacious and safe drug therapy over the longer term? What's the best model for drug delivery and monitoring strategies? And to move forward, robust and well-designed and well-supported research is urgently needed. So the CAS report did trigger a call in the UK for a study, which is still currently being designed. There's been a lot of controversy about how the study will be designed and implemented, but a lot of commentary back and forth on it. This is touched on the BBC actually as of, I think, yesterday. This piece in the BBC on this yesterday, discussing the pros and cons. The argument has been made it's unethical to deny gender dysphoric youth puberty blockers. The contrary argument has been it's unethical to give it to them unless you have good evidence. I think Gord Guyot, who is a professor of epidemiology at McMaster University, conflict of interest reveals, he was actually one of my teachers when I was doing my PhD, has made the point that that's unethical to move forward unless we have the evidence to support moving forward. And to move along the path, we need to get this sorted, and hopefully the UK will come to the research strategy in the shorter term to sort out how we move forward. I'd like to acknowledge, by the way, a couple of acknowledgements. First of all, the BPS, who supported this. I'd like to thank the BPS and organizers of this meeting. I would note that the British Journal of Clinical Pharmacology, of which I have the privilege of being one of the senior editors, has a themed issue on gender-affirming pharmacotherapy, of which we have authors on the stage here. I would encourage anyone with interest in this topic to review that issue. There's many relevant articles and manuscripts in that issue discussing these issues. I'd like to thank my fellow panelists for excellent introduction and perspectives. I'd like to thank the support staff for organizing this. I'd like to thank people who support our work. That's part of my work, and of course, Alice and Lauren's work. I'd like to thank my family who support me tracking across the Atlantic to meetings like this, and that's my lab group as well. And with that, I'd like to thank the audience for their attention, and I look forward to some robust discussion and comments moving forward. So with that, I'd like to remind you if you have a comment, please feel free to come to a microphone or put it into live chat, and Lucy will take care of bringing questions forward. So with that, I'd like to open this up for discussion and comments. And just as a first question while people are collecting their thoughts. So, Lauren, if you were designing the ideal study to move forward, how would you sort of think about the ideal study to address these questions?
Thanks for that question. I am a big advocate for probe substrate studies, which of course are challenging in youth. There are certain factors that you need to think about modifying, like serial blood sampling, but it can be done, and investigators have examined the effects of changes during adolescence in youth, and actually examined the effects on cytochrome P450s. So that's something that has been done. There's a track record for that, and I think that's really where we need to start. I think what's concerning is that a lot of it kind of doesn't matter where you fall if you have a strong opinion on medication therapy for trans youth. At the end of the day, we need to also be having a discussion around the pharmacology of these medications, and that seems to be lacking in most spheres. So yeah, probe substrate studies would be the first place to start, and then of course there's modeling that can be done, POP-PK and those types of things. Yeah.
Great. Are there questions, comments? And if not, I have a question for Alice, actually. Okay. So Alice, I'd like to get interested in your thoughts on, as I mentioned, sometimes the best drug therapy is no drug therapy. So what are your thoughts on issues of, and one of the other issues in the whole gender dysphoric area is phenotypic accuracy, i.e. diagnostic certainty. Do you have any thoughts on issue of how do we get to deciding who gets the drug? Because to get to a drug, you need a diagnosis. To get a diagnosis, you need to have a clear path. How clear a path do we have?
That's a very loaded question,
yeah,
Michael.
That's why I gave it to you, because I didn't want to ask it.
I don't know if I have the right answer to it. I would say my understanding is prior to this moment in time, access to gender-affirming hormone therapy was, and maybe Lauren can chime in too, was becoming more of a holistic or sort of I don't know, societal-based approach is the right term, but people could be referred to, to counselors by teachers, by therapists, whereas now it seems to be, it has to be, it's very medicalized. So it's only under the auspices of a research protocol, which doesn't exist yet, only can be for a very, diagnosed with gender dysphoria. I think it's sort of shifted from where it was. I know there are people who have very strong feelings both for and against it. I mean, I'm all for evidence, but I think we also have to be mindful of access.
I think you made a very important point that our colleagues in psychology have much to add to this discussion, and I think we've lacked that voice in a lot of this discussion. Microphone number 3 and then number 4, please.
So yeah, it sort of follows up on what you were just saying there. I guess in thinking of the optimum program to answer the question is, are puberty blockers for gender dysphoria or any of the other range of transgender issues the right way to approach this? What would be your ultimate efficacy study? How do you measure the quality of life improvements? How do you measure the potential harms? How do you set that bar, given that these are things that you need to look at over 20, 30, 40-year periods? How do you think that can be set up in advance? The pharmacology is great and interesting and why we're here, but ultimately, if we can't measure efficacy, how do we get that evidence that you're just referring to?
I think it's going to be a mix, and again, feel free to jump in, of assessing physiological changes that occur over time, as well as body image satisfaction, quality of life, mental health. Again, remembering that sort of circle holistic approach. I mean, medical care is only one component of providing gender-affirming care. So I think, reading some headlines, you might think, oh, somebody sneezes, they go on puberty blockers. It's not, I think that's a bit of an over hysterical reaction, and that's obviously not true. But I think you have to treat as broadly as possible, I think doing proper long-term follow-ups and documentation and not being afraid to report good outcomes as well as maybe some negative outcomes, because that's really what's going to inform and make your approach more balanced going forward. Lauren, did you want to comment?
Just to add on Alice's great response, I think one of the biggest challenges to the point raised is there is some individualization with care across the life course for transgender people. So that's why at this point, the most robust evidence we have comes out of the Netherlands because of how they've been running their clinic for the past 50 years. So your point is well taken. I wish we had a clear answer that we could give you today around how you would have a home run and design the perfect efficacy trial for pubertal blockers. But we need to also keep in mind that there is some variability with how different countries as well as different providers provide care for each patient. So makes it more complex.
We'll go to microphone 4 in a minute, but one of the questions in the chat is there a plan for longitudinal study to follow up on changes in PK platforms, populations?
At this stage, the evidence I've seen is really around specific therapeutic areas like HIV prevention. Those are areas where there have been some studies that have included transgender youth in their protocols. It's challenging because in those situations, the medication therapies that are being used are not clean probes for specific enzymes or transporters. So in those situations, they're really looking at the effectiveness of HIV prevention. So those are the current studies I've seen specifically. And in those cases, most of the participants that are transgender youth have been on hormone therapy specifically, so either testosterone or estrogen. So I don't know if Alice is aware of any other.
No, I can't, other than that, no.
Yeah, I mean, it's a good plan. An observation would be as well, there's a general lack of ontology studies in adolescence anyway, period, full stop, because there are many changes that occur, especially pharmacodynamic. Like there are lots of drugs in which cannabis is a good example. So cannabis probably causes anxiety in teenagers, doesn't decrease it. Affects maybe in older people. So I think there's a general lack of ontogeny period in that population, which doesn't help things. We're going to go to microphone 4 and then maybe a couple of the other questions on the chat, please and thanks.
Thank you. I work in pharmacovigilance. Giving hormones to people, the detrimental effects are usually long-term, hormone replacement therapy and so on. Whenever you manipulate hormones, the effects are long-term, and many of the studies which we have seen are short-term, perhaps very short-term. The other point is that there is evidence that females who receive testosterone for hyposexual drive can be associated with breast cancer. So when you give testosterone, that has been associated. And the third point is the risk-benefit. We have just heard how nebulous demonstrating the effectiveness in the real world, and it's social, personal, as well as clinical. And the safety is long-term, and we know that we don't do well with long-term effects. Though the whole thing is nebulous, and in those countries where it is used, what is the chat between the providing doctor and the person about the long-term effect and the risk-benefit? What data are they providing them with long-term benefit? I'm sorry, I raised a number of points, but I think all of them are relevant.
So Lauren, what's the Dutch experience with that? Do you know about the consent protocol?
Well, so thanks for that question. And there has been, again, the Dutch do this best because they've had a very robust way of following patients that they've provided medication therapies to, again, over 50 years. And during the consent process, I'm not familiar with how the Dutch specifically counsel patients. In the US, there's an informed consent process, speaking about adults. And during that stage, the risks are reviewed with patients. We are trying to balance that risk-benefit ratio, and that's not unique to gender-affirming care. So that is based on available evidence. Providers certainly do give information about potential harms down the line, about cardiovascular risks. From the Dutch studies, we do have some evidence around the implications for cancer risk, and I would argue that the data there have been encouraging. I do understand that there are some situations, like you mentioned, where, sex steroids are associated with cancers. And that's true for people who are not transgender, as well as transgender people. The data that we have around cancer risk has actually been very reassuring. But yeah, nothing is risk-free, and experts will try their best to make sure that patients are aware of not only the risks we know of, but the gaps in knowledge around what we don't know.
Speaking of gaps in knowledge, a good question. Are there any animal or preclinical models for transgender populations? I'm unaware of any, but...
Yeah, there are. There's a group in Michigan that is working around murine models.
Okay.
It's challenging. There's like SHBG is one of the proteins that we can't really replicate in those models, but they are at least trying to develop in vivo an animal model that can be used to further examine the effects of sex steroids.
Thanks. We'll go to microphone 3, please.
Thank you. So I deliver some teaching on this for If I Know Your Undergraduate students, and we debate this. Obviously, it's very politicized as well. I think it's difficult to remove just the science. So my question is, from your opinions, are there other avenues of medicine that you feel maybe do not have the evidence basis that things like the Cash report are calling for with transgender medicine, but there's other avenues that maybe aren't as politicized that we're not really looking at as much as we should? I know that's maybe not your area of expertise, but it'd be nice to sort of think about, is there anything else that we need to be investigating, not just a marginalized group already? Thank you.
Well, there's, at least in pediatrics, there's definitely lots of areas in which we don't have evidence to support care, and that's for sure. The challenge is, I'm going to speak from the Canadian guidelines. So the Canadian Pediatric Society guidelines on use of puberty blocking agents are based on really no evidence at all. And as someone who's written set guidelines for the organization, that is actually is discordant with other guidelines. So there are guidelines we wrote, for instance, bronchiolitis, which is common viral disease in children. There's not a lot of evidence, but we actually say that there's no evidence. We listed it out. So there's a bit of a concordance there. I agree with you. A very politicized issue, one way or the other. And there's lots of places in therapies we use in medicine that don't have much evidence, but very few of them have been heavily politicized as this one.
I would say one good example is in HIV, post-exposure prophylaxis, which is a protocol where you give 3 medications after potential exposure to prevent HIV acquisition. Really, that initial concept was based on animal models with a single drug. But then when triple therapy for HIV became standard of care, we just reverted to using 3 drugs for this post-exposure prophylaxis for 28 days. There has never been a prospective randomized trial to compare, 1 drug versus 2, 1 drug versus 3, 28 days versus 2 weeks, and that will never happen. Yet I think it's pretty accepted practice, and it would be hard to walk back from that.
Great. Well, with that, we've hit the mark. I would like to thank the audience for their participation. I would like to thank my fellow speakers. I'd like to thank BPS for organizing it. Thank you for coming out to Harrogate. Hope everyone having a good meeting, and look forward to seeing you guys for the next 2 days.